Hello and welcome. Today we are going to cover a very interesting topic on acid-base balance within our bodies. It is very important to understand what components contribute to acid-base imbalances, and we will also learn different types of acid-base imbalances. We'll learn their causes, clinical manifestations, and their management in a clinical setup. Finally, we will tackle various acid-base imbalance questions that can be tested on NCLEX. So, again, welcome and let's learn together. As we begin this topic on acid-base balance, it is important to understand a specific test used to monitor acid-base balance within the body, especially for the sick and acutely unwell patients. ABG test includes measurements of acidity, that is the pH, carbon dioxide, oxygen, and bicarbonates. This test includes a blood sample for an arterial blood gas that is taken from an artery. As you can see from the diagram, the arteries that we usually draw blood for the ABG test are like the radial artery, brachial artery, dorsalis pedis artery, and the femoral artery. Interpreting blood gases is used to detect whether we have a respiratory acidosis or respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. There are some things that we need to understand. Number one is the pH. pH is the measure of acidity. The normal body pH is between 7.35 to 7.45. The other thing is bicarbonate, HCO3. Bicarbonate levels should be between the 22 to 26 millimoles per liter. A bicarbonate ion is an alkaline substance that comprises over 50% of the total base in the blood. PaCO2. PaCO2 levels is the partial pressure of carbon dioxide. The normal should be between 35 to 45 millimeters of mercury. PaO2 is the partial pressure of oxygen. The normal should be between 80 to 100. SO2 is the oxygen saturation. The normal should be between 94 to 100%. Be is the base excess. The normal range is -2 to +2 millimoles per liter. A base excess of less than 2, that is -2, is acidosis. A base excess of less than -2 is acidosis, and greater than +2 is alkalosis. So if the pH levels are below 7.35, partial pressures of carbon dioxide above 45, and bicarbonates below 22, that is a situation we call acidosis. If the pH levels are above 7.45, partial pressures of carbon dioxide below 35, bicarbonates above 26, the problem is alkalosis. And something that is also important to note is the potassium levels. The normal potassium levels are between 3.5 to 5.0 millimoles per liter. Potassium levels are increased in acidosis and decreased in alkalosis. So when the client is experiencing acid-base disturbance, monitor potassium levels very closely. So when interpreting arterial blood gas results, determine if the problem is acidosis or alkalosis. The second thing, you need to look at the lab values and see whether they define a metabolic or a respiratory problem. The other thing is that you need to check the state of compensation, whether it is fully compensated, uncompensated, or partially compensated. So after you determine whether the problem is acidotic or alkalotic by looking at the pH, you need to determine whether the problem is a respiratory or a metabolic problem. The respiratory function indicator is the partial pressure of carbon dioxide, PaCO2. So the pH and the PaCO2 have opposite relationship in a respiratory imbalance. So you need to look at the pH and the PaCO2 to determine whether the problem is a respiratory disturbance. The pH will be low and the partial pressure of carbon dioxide will be high in respiratory acidosis. For example, you can have a pH of 7.21 and a PaCO2 of 48. In respiratory alkalosis, the pH will be high and the partial pressure of carbon dioxide will be low. For example, you can have values like a pH of 7.47 and a PaCO2 of 32. The metabolic function indicator is the bicarbonate, that is HCO3. The pH and the bicarbonate usually have the same relationship. They go in the same direction in a metabolic problem. So look at the pH and the bicarbonate to determine whether it is a metabolic disturbance. And in metabolic acidosis, the pH will be low and also the bicarbonate will be low. For example, pH of 7.21 and the bicarbonate values of 19. That is metabolic acidosis. When you have values where the pH is elevated, like let's say 7.52, and the bicarbonate is also elevated like 47, that defines metabolic alkalosis, because in metabolic alkalosis the pH is high and the bicarbonates are also high. The relationship is the same. They go in the same direction in metabolic disturbances. So from the quick reference you are seeing on your screen, we have blood gas analysis results. It can be respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So when there is a respiratory acidosis, the pH is low, the carbon dioxide is high, and the bicarbonates are normal. In respiratory alkalosis, the pH is high and the carbon dioxide is low and the bicarbonates are normal. Remember, we are looking at the partial pressures of carbon dioxide because that is the respiratory function indicator. The metabolic function indicator is the bicarbonate, so you are going to look at it together with the pH. In metabolic acidosis, pH is down, bicarbonate is also down. Metabolic alkalosis, pH goes up and also bicarbonates goes up. Sometimes you can have the trend of carbon dioxide and bicarbonate going in the same direction, and this means that when you look at the partial pressures of carbon dioxide and bicarbonate, they can indicate either alkalosis or acidosis. And what you need to do to determine whether it is a metabolic or a respiratory problem, you need to check the percentage difference of the values that have been given to be able to know which one is the dominant disorder. For example, you can be given a pH of 7.25, bicarbonate of 16, and partial carbon dioxide of 60. So here the pH is acidotic. Both carbon dioxide and bicarbonate explain that it is acidosis. So we need to look at the percentage difference. Remember, the normal bicarbonate levels are between 22 to 26. The mean of between 22 and 26 is 24. So you need to take 24, subtract the given value, which is 16, divide by 24, you'll get 0.33, multiply by 100 to get 33%. Carbon dioxide difference, you know that the normal is between 35 to 45. The mean is 40. So you need to take what is given, that is 60, minus 40, divide by 40, you'll get 0.5, times 100, you'll get 50%. So you find that In this case, the carbon dioxide is at 50% and bicarbonate at 33%. Therefore, the respiratory acidosis is the dominant disorder, because we said the partial pressure of carbon dioxide, which is now at 50%, is the indicator for the respiratory function. Now let us look at compensation. Compensation refers to the body processes that occur to counterbalance the acid-base disturbance. When you look at the ABG analysis, determine if the situation is compensated, partially compensated, or uncompensated. It is fully compensated if the pH is normal. It is partially compensated if all the three values are abnormal. It is uncompensated if carbon dioxide and bicarbonate is normal and the other is abnormal. For example, let us look at fully compensated respiratory alkalosis. You may have values like 7.44 of pH. 7.44 is normal, but on the higher side, which is alkalotic side, but it is still within the normal, meaning it is compensated. PCO2 of 30 and bicarbonate of 21. Uncompensated case is whereby you can have a pH of 7.1 and that one it means it is acidotic. Uncompensated metabolic acidosis, pH 7.1, carbon dioxide of 40 and bicarbonate of 18. That is uncompensated metabolic acidosis. Because in an uncompensated case, the partial carbon dioxide is within the normal range, and the bicarbonate, as you can see, it is at 18 is low, but also the pH is abnormal. So that is uncompensated metabolic acidosis. Partially compensated metabolic acidosis, you need to look at all the values, the pH, partial carbon dioxide, and bicarbonate. All of them will be abnormal. For example, 7.26 pH, that is abnormal, it is low. Carbon dioxide of 32 is still low, abnormal, and now that shows it's a compensated metabolic acidosis, and also bicarbonates of 18, that is partially compensated metabolic acidosis. Something that you need to monitor very closely is the respiratory status of the patient, because during compensated acidosis, the respiratory rate and depth increase in an attempt to exhale the acids. During compensated alkalosis, the respiratory rate and depth decrease. Carbon dioxide is retained to neutralize and decrease the strength of the excess bicarbonate. Sometimes you can have mixed base disorders. A mixed base disorder or a disturbance is where there is more than one primary disorder at a time. It often occurs in acutely unwell patients. These mixed disorders include combinations of metabolic disorders, that is the vomiting-induced metabolic alkalosis, plus hypovolemia-induced lactic acidosis. You can also have mixed metabolic and respiratory disorders. For example, metabolic acidosis and respiratory alkalosis for an example of salicylate intoxication.
Hello and welcome all. Welcome to the NCLEX Made Simple YouTube channel. Here is whereby we try to make the NCLEX content as simple as possible to help you pass the NCLEX within the first attempt. It is easy and it is doable. All you just need is to read, and here we have simplified this content as simpler as we can. I'm Mr. Iradi Muturi, that's my name. And today, I'll be taking you through the acid-base balance, and I'll start with respiratory acidosis. And we define what is respiratory acidosis. By definition, it occurs when breathing is inadequate, or when we have, when we have something we call alveolar hypoventilation, whereby we have a lot of CO2 being produced in the lungs, and the lungs are not able to excrete this carbon dioxide, thereby it ends up accumulating in the lungs, increasing the partial pressure of carbon dioxide in the body. What are some of the risk factors which can cause acid-base balance, which can contribute to respiratory acidosis? Some of the risk factors which can contribute to respiratory acidosis. One, and the name suggests respiratory, we have some respiratory condition such as chronic obstructive pulmonary disease, or what we call COPD. And normally what happens in COPD is that there is accumulation of CO2 in the lungs, and the body will try to compensate. The body will try to compensate by retaining more bicarbonate in an attempt to overcome the acidosis that results from the accumulation of carbon dioxide. Remember, carbon dioxide is a gas. It's produced in the lungs and it is acidic in nature. Remember that. Always remember, carbon dioxide is a gas. It's produced in the lungs and it is acidic in nature. So in COPD, there is the accumulation of that carbon dioxide gas. And now the body, in an attempt to compensate, they will try to retain more bicarbonate to overcome this acidotic state being brought about by the accumulation of carbon dioxide. Respiratory conditions such as emphysema, asthma, pneumonia, pneumothorax can also contribute to respiratory acidosis. Basically, what is happening in this respiratory condition is that the lungs are not able to eliminate enough of the CO2 being produced by the body. So we will have excess carbon dioxide accumulating in the lungs. And we have just said that CO2 is a gas. It's produced in the lungs and it is acidic in nature. And when this CO2 accumulates, it will cause the pH of the blood and other bodily fluids to drop. And remember, we say the less the pH, the more the acidic we becomes. Drug intake, overdose of opioids can also contribute to respiratory acidosis. Opioids, remember from your pharmacology, we have morphine, tramadol, heroin, fentanyl. Another drug which can contribute to respiratory acidosis, but it's not an opioid, it's magnesium sulfate. This one, we normally use it in REBA for patients who have eclampsia and pre-eclampsia. And now we are going to look at the signs and symptoms of respiratory acidosis. And we are going to start with a very common examinable sign and symptom. Remember, with respiratory acidosis, we have hypoventilation with hypoxia, and hereby the lungs are unable to compensate when there is a respiratory problem. But in some conditions, such as in diabetic ketoacidosis, in an attempt to compensate, the patient will have deep, rapid respirations, and these respirations, we call them Kussmaur's respirations. Remember that for your NCLEX. Another sign and symptoms is altered level of consciousness. Respiratory acidosis can result to a patient having altered level of consciousness, which can be brought about by encephalopathy or cerebral edema. Still on the brain, the patient can exhibit signs such as confusion, drowsiness, stupor, or muscle jerks. The patient can also exhibit signs such as disorientation, headache, or other focal neurologic signs when they have respiratory acidosis. Another common sign we normally see in patients with respiratory acidosis is coma. With the accumulation of carbon dioxide in the body, carbon dioxide which is a gas, and the lungs are unable to excrete all of it, we end up accumulating this carbon dioxide in the lungs and eventually in the body. And carbon dioxide being a gas, as it accumulates, it lowers the blood pH, so we become more acidotic. And when in an acidotic status, these are very bad status, the patient can exhibit signs from sleepiness to completely being in a coma. Remember, also coma is a sign and symptom of respiratory acidosis. The patient can also exhibit signs and symptoms such as tremors, which will manifest as shaking or jerking muscle movements. And another sign and symptom of respiratory acidosis is asterixis, whereby the patient is unable to maintain one body posture. Now look at the management of a patient with respiratory acidosis. And generally, the medical and the nursing management of an arterial blood gas of respiratory acidosis will include treating the underlying conditions. Remember the conditions which have contributed to the acid-base imbalance of respiratory acidosis and manage such. For example, for asthma and COPD, the patient may have airways, the patient airway may be vasoconstricted, so administer corticosteroids and bronchodilators in an attempt to open the airway and reverse the airway obstruction. We may also encourage weight loss. This one may be in the case of obesity-linked hypoventilation, where in such cases significant weight loss may be necessary to reduce abnormal compression of the lungs. You can also provide mechanical ventilation through oxygen supplementation. Additional oxygen may be provided to alleviate the low oxygen levels in the blood. Remember, we have a lot of CO2 accumulating in the body, and when CO2 accumulates in the body, the oxygen levels will definitely go down. So in an attempt to raise the oxygen level, we can give oxygen as a supplemental mechanism to try and raise the levels of oxygen in the blood. We also have to manage hyperkalemia through the use of kayexerate. Remember, one thing I would like you to remember from now on is that acidosis causes potassium to move from the cells to the extracellular fluid, that is from the cells to the blood, to the plasma. When I talk of extracellular fluid, I'm talking of the plasma, the blood, in exchange for hydrogen ions, and alkalosis will cause the reverse movements of potassium and hydrogen ions. What kayexerate does, it increases the fecal excretion of potassium through the binding of potassium in the lumen of the gastrointestinal tract. So hyperkalemia contributes to acidosis, and in an attempt to lower this hyperkalemia, or that is high levels of potassium in the body, potassium levels above 5.0, we can give an enema, which is kayexerate, to try and eliminate or excrete the potassium, thereby reducing the levels of potassium in the body. And another thing we can do as a nurse, maintain adequate hydration, provide intravenous fluids, and electrolytes as ordered. We now look at our next acid-base balance, which is respiratory alkalosis. And this one results from conditions that cause overstimulation of the respiratory system. Mostly be remembering, when we have overstimulation of the respiratory system, we now have hyperventilation. In acidosis, we had hypo. Now with alkalosis, it is hyperventilation. As the pH goes up, so goes my patient. Always remember that. So in alkalosis, the pH is higher, so everything will go high. So we have hyperventilation. What are some of the causes of respiratory alkalosis? It's anything that can cause our patient to hyperventilate, anything that can contribute to overstimulation of the respiratory system. Some of the conditions which can result to that, we have fever. When a patient is having fever, or hypothermia, that one can cause overstimulation of the respiratory system, and the patient will hyperventilate. Aspirin toxicity, or what we call salicylate toxicity, this one can also contribute to respiratory alkalosis. Another condition which can contribute, another cause which can lead to respiratory alkalosis is diabetic acidosis. DKA is the only known compensatory response to metabolic acidosis. What happens with DKA is that the patient will hyperventilate in an attempt to compensate, hence having consecutive respiratory alkalosis. Another cause of respiratory alkalosis can come about as a result of brainstem damage. And what happens in this one, we have something we call central neurogenic hyperventilation, CNH, whereby this is the human body response to reduced carbon dioxide levels in the blood, and this reduction in the CO2 levels is normally caused by the contraction of cranial arteries from damage caused by lesions in the brain stem. Pregnancy can also contribute to respiratory alkalosis. In pregnancy, we have an hormone which is produced, which is called progesterone, and these levels are normally raised or increased during pregnancy, and progesterone causes stimulation of the respiratory center, and with the stimulation of the respiratory center, we will have hyperventilation, and that one can lead to respiratory alkalosis. Hypoxia, this can also lead to respiratory alkalosis, whereby we have the respiratory center being overstimulated. Pain can also lead to respiratory alkalosis. When someone or when a patient is having severe anxiety and hysteria, remember they will overstimulate the respiratory system, and this will cause hyperventilation, which will contribute to respiratory alkalosis. And another cause is overstimulation by mechanical ventilation, whereby we can pump excessive oxygen, and this one will overstimulate the respiratory center, making the patient to hyperventilate, and this will be another cause for respiratory alkalosis. Let us now look at the signs and symptoms of respiratory alkalosis. Remember, we said that in respiratory alkalosis, we have overstimulation of the respiratory system. And when the respiratory system is overstimulated, we have hyperventilation. So hyperventilation is a sign that respiratory alkalosis is most likely to occur. However, low carbon dioxide levels in the body or in the blood may also contribute to a number of physical effects, which can include numbness, and numbness is increased neuromuscular irritability in which a person loses feeling in a particular part of their body. We can also have another sign and symptom, which is tingling sensation. A patient with respiratory alkalosis can exhibit prickling sensation that is usually felt in the hands, arms, legs, or feet, but can also occur in other parts of their body. They can also exhibit something we call palpitations, which are perceived abnormality of the heartbeat characterized by awareness of cardiac muscle contractions in the chest. They can also exhibit tetany. Tetany, or what we call tetanic seizure, is a medical sign consisting of the involuntary contraction of the muscles. Respiratory alkalosis patient can also exhibit conversion, which is a medical condition where body muscles contract and relax rapidly and repeatedly, resulting in uncontrolled actions of the body. Another important point I would have you to remember for the purpose of your exam also is that signs and symptoms of hypokalemia and hypocalcemia can also be brought about or be seen in patients with respiratory alkalosis. And what normally happens here is that persistent respiratory alkalosis can induce secondary hypocalcemia and hypokalemia that may cause cardiac arrhythmias, conduction abnormalities, and various somatic symptoms such as paresthesia, hyperreflexia, convulsive disorders, muscle spasm, muscle twitching, positive Chefotek sign, and tetany. Remember the hallmark signs for hypocalcemia. We have the positive Chefotek sign, which is the twitching of the facial muscles, and tetany, that's another hallmark sign for hypocalcemia on the NCLEX. Tetany, remember capopardid spasms when you inflate a blood pressure curve. Always remember that. Let us now look at the management of respiratory alkalosis. In the management of respiratory alkalosis, the treatment aims at increasing the carbon dioxide levels in the blood, and the following strategies and tips are useful for respiratory alkalosis, which can be caused by overbreathing due to panic and anxiety. Remember, one of the causes of respiratory alkalosis, we said severe panic and anxiety and hysteria can contribute to respiratory alkalosis. One of the strategies to manage this, we can have the patient breathe into a paper bag. What basically happens here is that breathing through a paper bag, it infuses it with carbon dioxide, and this one helps in inhaling back the air into the lungs. We also treat underlying conditions. Medications such as opioids can be administered for pain. Remember, pain was also another cause of respiratory alkalosis, whereby we send a patient or a patient who is experiencing pain can also have hyperventilation due to overstimulation of the respiratory center. We can also administer anti-anxiety medication to reduce hyperventilation. Remember, severe anxiety, panic and hysteria was a cause of respiratory alkalosis. Relaxation techniques. Respiratory alkalosis, we have overstimulation of the respiratory center leading to hyperventilation. Here in relaxation technique, teach the patient breathing exercises that help relax and breathe from the diaphragm and the abdomen rather than the chest wall. Safety, as a nurse, safety NCLEX is all about safety. Don't leave the patient. Stay with the patient. Revenge. Remember, one of the causes for respiratory alkalosis was aspirin, or what we call salicylic toxicity. What happens is that after massive aspirin injection, aggressive gut decontamination is advisable, including gastric lavage. We also correct hypokalemia and hypocalcemia. Remember, we think that hypokalemia and hypocalcemia can secondarily be induced by respiratory alkalosis. Another very important key factor in management is oxygenation, as indicated. Provide oxygen to help keep a person from hyperventilating. Let us continue with acid-base balance. We now look at metabolic acidosis. And metabolic acidosis occurs when there is a decrease in bicarbonate and a building up of lactic acid. And this one normally happens in diarrhea, ketosis, and kidney disorders. It has three main causes, which are increased acid production, loss of bicarbonate, and a reduced ability of the kidneys to excrete excess acids. What I mean by, remember, bicarbonate is a base, and this base is produced in the kidneys. So when we lose the base, our bodies become more acidotic. That's why we are seeing loss of bicarbonate and a reduced ability of the kidneys to excrete excess acids. What are some of the risk factors which can predispose a patient to have metabolic acidosis? The most common is diabetic ketoacidosis, or what we call DKA. And DKA develops when there are ketones building up in the body. Ketones are acidic, and they build up during uncontrolled diabetes. DKA, it mostly occurs in diabetic mellitus type 1. Another very common risk factor which can predispose a patient to develop metabolic acidosis is chronic renal failure. This one is due to reduced tubular bicarbonate reabsorption and insufficient renal bicarbonate production in relation to the number of acid synthesized by the body and ingested with food. Remember, the function of the kidneys, excretion and production of the bicarbonate ions. So what is basically happening with chronic renal failure? Our kidneys are failing to produce enough bicarbonate ions, and also at the same time they are not able to excrete the excess lactic acid which is being produced in the body. That is what is happening. Another very common risk factor is chronic hypoxia, and with chronic hypoxia, metabolic and hypercapnic acidosis develop along with considerable lactate reduction, along with considerable lactic formation and pH falling to below 6.8 levels. Another risk factor for metabolic acidosis is obesity. Obesity, especially with insulin resistance, can increase metabolic acidosis and thus result in reduction of urinary citrate excretion. Another common cause of another risk factor or a cause of metabolic acidosis is diarrhea. With diarrhea, we have loss of bicarbonate ions through diarrhea, and this will lead to metabolic acidosis state characterized by increased plasma chloride concentration and decreased plasma bicarbonate concentration. Another risk factor for metabolic acidosis is dehydration, whereby we have electrolyte disturbances by prolonged vomiting or severe dehydration can cause metabolic acidosis. Aspirin toxicity. Aspirin overdose causes the body to not produce ATP, or what we call adenosine triphosphate, leading to anaerobic metabolism with consequent raised balance and ketone bodies. Acute aspirin or salicylic overdose or poisoning can cause initial respiratory alkalosis through metabolic acidosis. Will ensue thereafter. Another risk factor is methanol poisoning. Significant methanol injection leads to metabolic acidosis, which is manifested by a low level of serum bicarbonate, whereby the anion gap is increased secondary to high lactate and ketone levels, which is probably due to formation of acid due to formic acid accumulation in the body. We now look at some of the signs and symptoms of metabolic acidosis. This one we just highlight for the purpose of remembrance for your exam. One of the signs and symptoms of metabolic acidosis is confusion with high acid levels in the body. Remember, they are not good for the patient. The patient can experience confusion. The patient can also exhibit signs and symptoms of disorientation, lack of appetite, heightened level of consciousness. Also remember, with high acid levels building up in the body, the patient can experience sleepiness, which can progress to coma. And another very common sign and symptom we can see with the metabolic acidosis is normally jaundice. Let us now look at how we can manage a patient with metabolic acidosis. Basically, patient with arterial blood gas indicating metabolic acidosis are managed and treated by 1. We administer sodium bicarbonate It is normally indicated in the treatment of metabolic acidosis, which may occur in severe renal disease, uncontrolled diabetes, circulatory insufficiency due to shock or severe dehydration, extracorporeal circulation of blood, cardiac arrest, and also in severe primary lactic acidosis. We also treat the underlying condition which can be contributing to metabolic acidosis in the patient. For DKA, we can do hydration. That is the major treatment of this condition and is the initial step in rehydrating the patient. For chronic renal failure, we can do dialysis. That is for the control of metabolic acidosis in hemodialysis. Is mainly focused on the supply of bicarbonate during the dialysis session. We can also use diuretics in chronic renal failure, for example. Another one is initiate safety measures for the patient. Remember, don't leave your patient. The NCLEX is about safety. Safety will always come as the number one and the main point. Another one, we can give or administer an enema which is called Kayakzerate. This one, what basically is that, what is basically happening when we give an enema known as Kayakzerate, that acidosis causes potassium to move from cells to the extracellular fluid. That is, from the cells to the plasma or to the blood in exchange for hydrogen ions. And alkalosis will cause the reverse movement of potassium and hydrogen ions. Kayakzerate in our case will increase fecal potassium excretion through the binding of potassium in the rumen on the gastrointestinal tract. We now proceed with metabolic alkalosis. We are still on the acid-base balance. Let us look at metabolic alkalosis. And metabolic alkalosis occurs when bicarbonate ion concentration increases, causing an elevation in blood pH. Remember, with alkalosis, the pH goes up. And we said bicarbonate is a base. So when bicarbonate increases, we become more basic, and this will raise the pH. And this can occur in excessive vomiting or endocrine disorders. What are some of the risk factors which can contribute to metabolic alkalosis? One of them is vomiting. Vomiting causes metabolic alkalosis by the loss of gastric secretion such as hydrochloric acid. A lot of gastric secretion are rich in hydrochloric acid, which is an acid produced in the stomach to aid in the digestion of food. Whenever a hydrogen ion is excreted, a bicarbonate ion is gained in the extracellular space. Just remember that. Another risk factor for metabolic alkalosis is sodium bicarbonate overdose. Basically, what happens here is that administration of sodium bicarbonate in amounts that exceed the capacity of the kidneys to excrete will cause this bicarbonate to build up. And when the bicarbonate build up, remember bicarbonate is a base, we will be having more base in the system, which may result in metabolic alkalosis. Another very common cause of metabolic alkalosis is hypokalemia. That one develops due to low extracellular potassium concentration, whereby potassium shifts out of the cells. So in order to maintain electrical neutrality, hydrogen shifts into the cells, raising the blood pH. That is what is happening in hypokalemia. Another risk factor or cause which can make a patient develop metabolic alkalosis is nasogastric sanction. Just like vomiting, nasogastric, or what we call NG sanction, also generates metabolic alkalosis by the loss of gastric secretions which are rich in hydrochloric acid. Let us proceed, and now we look at some of the signs and symptoms of metabolic alkalosis. A patient with metabolic alkalosis can exhibit the following signs and symptoms. I'll just highlight them: numbness, vomiting, diarrhea, fatigue, tingling sensation, swelling in the lower legs, or what we call peripheral edema, agitation, disorientation, seizures, and even coma. We now look at the management of metabolic alkalosis. How do we manage a patient with metabolic alkalosis? Number one, we can administer antiemetics, medicines such as ondansetron, promethazine. That is in case of a patient with vomiting, and administer antiemetics if possible. We can also administer ammonium chloride. Ammonium chloride is a systemic and urinary acidifying agent that is converted to ammonia and hydrochloric acid through oxidation by the liver. Intravenous ammonium chloride is a treatment option for severe cases of metabolic alkalosis. So for patients with very severe cases of metabolic alkalosis, that's when we use ammonium chloride. Another option or another medicine we normally use, we call it Diamox or acetozolamide. Acetozolamide also appears to be safe and effective in patients with metabolic alkalosis following treatment of respiratory acidosis from exacerbation of chronic obstructive pulmonary disease.
So the other important thing that we need to learn is the Allen test. Allen test is a procedure done before radio artery puncture when you're obtaining blood for the blood gas analysis. The procedure for the Allen test, first of all, you need to explain the procedure to the client and including its purpose, which is to assess the collateral circulation. So what you do, pressure is applied over the ulnar and radial arteries simultaneously, like this. You apply pressure on the ulnar and radial artery simultaneously, like this. And the client is asked to open and close the hand repeatedly. Open, shut, open, shut, open, shut. And then pressure is released from the ulnar artery, where the radial artery is when the radial artery is still being compressed. Then you assess the color of the extremity distal to the pressure. Keep opening and shut, open and shut, open, shut, open, shut. Now you can see that the color is almost white, but when I release the ulnar artery, it becomes flushed. All the blood comes to the distal areas. You can see the hands and the fingers are now pink in color. That is the Allen test. If the test is negative, the hand will not experience flushing of blood. But if the test is positive, the fingers turn pink, meaning there is flushing, and you can go ahead and draw the blood from the radial artery. So when you finish doing that, the findings are documented.
We have now come to the end of the acid-base balance NCLEX topic review, and as usual, we would like to test your knowledge by you taking some NCLEX style practice questions. You test your knowledge as you review the rationale to see where you have gone wrong or whether you have got it, and run from the test taking strategy and the answers expressed in the rationale one or two tricks on how to approach your NCLEX questions on the real exam. Also, on that note, if you'd like to come back again and review this topic, you can always watch and rewatch it on the NCLEX Made Simple YouTube channel. And remember to also subscribe and to also invite your friends who are struggling with the acid-base balance. Let them come and watch this video. All the best in your NCLEX style questions.
destiny. Never will you be alone in the dark anymore. Open your eyes, look into my heart. Rain and the storms, I will stand by your side. As seasons go on, till our hair fades to gray. All the days and the nights, we will be together. I will hold you tight to me. All that I want is your love. Oh baby, I'm so addicted to you. Let me give you my heart, my mind, oh my soul. See, I do believe it's the way it should be. There's heaven above, this is our destiny. Never will you be alone in the dark anymore. Open your eyes, look into my heart. Rain and the storms, I will stand by your side. As seasons go on, till our hair fades to gray.
Every time I train myself because of you. If you wanna be in my way 'cause of me, the stars were shining to me away, whispering, I want you to know you're my world. Every time I'm crazy, it's because of you. If you're looking right in me because of love, to me it's a pretty wonderland. Do not make me cry again. I need you right now. I'm gonna be fine. You left me alone. Can I heal the wounds? Every time I train myself because of you. If you wanna be in my way 'cause of me, the stars were shining to me away, whispering, I want you to know you're my world. Every time I'm crazy, it's because of you. If you're looking right in me because of love, to me it's a pretty wonderland. Do not make me cry again. I need you right now. I'm gonna be fine. You left me alone. Can I heal the wounds? My
Well, we have come to the end of our topic, acid-base balance. I hope all the nuggets that we have provided for you will help you to understand fully this topic. And if there's an concept that you have not understood properly, you can always rewatch this video in our YouTube channel at NCLEX Made Simple. Just go to YouTube, type at NCLEX Made Simple. You'll find us there. We have more videos uploaded there, and those videos are for you. We will continue supporting you in your journey. We want you to pass the NCLEX, and we want all you to be able to practice nursing in your dream country, whether it is Australia, Canada, America. We are here with you. We have made this journey simple for you. Just continue watching our videos, and I'm sure they will be of great value for you. Thank you so much. Let's see each other in the next video.
I know for sure that it's not true. I'm saving all my heart just for you. Won't you